I'm Rob.
And I'm Mike.
And welcome to a special edition of Let's Get Ethical.
Welcome, everybody, to another episode of Let's Get Ethical. Today, we're actually doing this in collaboration with RT Sidebar. So before I go any further, I want to welcome Maddie P, JJ the RT, and the Taylor Swift of respiratory care, Mindy Conklin. Thank you guys for joining us. We're so happy to have you. Rob, not to be left out, how you doing today?
I'm good, buddy. How you doing?
I'm good. How's your foot?
It's healing, man. It's healing. It's slow. It's a slow process.
Yeah. Well, everybody, we are here today on a special episode that is releasing on Saturday, May 30th. Completely out of the norm for our release dates, but there's something important that we need to come together and discuss. And I want to start with, I don't think we're going to get anything solved today. But everybody's got something to say. Everybody has a different vantage point, and we need to understand and receive all of that. So a couple weeks ago, Mayo Clinic made an announcement. They had an internal memo that got actually leaked to ABC 6 News out there. And the memo stated that as of August 26th of this year, there are 3 sites that are no longer going to be having overnight respiratory care. Which means no respiratory therapist overnight. That immediately popped off on social media with people getting worried. And this is Mindy and Rob. This is on the back of our coronavirus and now Ebola conversations that occur. Just more trauma for us to deal with, more things that we're having to deal with in our profession and in healthcare. I've seen arguments on both sides of it. And I kind of know where I stand, but rather than taking the entire floor the entire time, I'd like to start with RT Sidebar. Matt, JJ, Mindy, do you guys have thoughts? You guys obviously have seen this. Everybody knows what's going on. What are your initial thoughts? Matt, go ahead.
So first off, thank you guys. Let's Get Ethical is so freaking awesome. I love them so much. And thank you for inviting us. Mindy, JJ, and I love collaborating with you guys. So that's first off. The second thing I want to say is the Mayo Clinic respiratory department are phenomenal people. They are great respiratory therapists, and we look up to them. This has nothing to do with them.
I will cut in really quick to agree with you and say that I have a number of graduates who work at Mayo.
Mm-hmm. And I've met a lot of graduates. I've been to the Mayo Clinic. I've been very impressed. I know in my heart that this was a tough decision for them. And I think that we have to be respectful to them first, that whatever decision that they make, it's easy for us to poke and prod and play Monday morning quarterback. But I want to first say that I think the Mayo Clinic is a great place to deliver healthcare. And I think that this decision was not made in haste. That's all I want to say. Mindy. You've been very popular.
Yeah, I agree. Mm-hmm. It's definitely something that it's not the only hospital system that has done this. I know there's one in Louisiana that has standalone ERs that don't have respiratory therapists there day or night. So that's probably several other ones that we don't even know about. Do I think virtual RT is a good idea? It can be a good idea. Do I think not having an RT in the hospital at night, when we know that nighttime things still happen, people still have COPD exacerbations, people still need intubated, I don't think that's ethical either, not to have a RT there in person. But I'm not against having a virtual RT because there is someone there to coach the doctors or the nurses through if there is a critical situation. From the sounds of it, they're not very busy in the evenings. But I can see both ways.
Okay. JJ.
What do you think?
Yeah, for me, in my role now as an educator, part of the concern that I have is I'm encouraging all of these students that we graduate that this is going to be a profession that is going to be here longstanding. And you get a hospital and a system like Mayo Clinic that is diminishing our numbers during a certain time frame. There are plenty of people who have graduated with a degree over the last 15, 20 years that do not work within that degree, within that field. And I've never felt that way about respiratory therapy. But when we get systems that are as big and as wide and well known as Mayo Clinic, it gives me a cause for pause as an educator to say, hey, look, student, you come in and you put in as much work as it takes to become a respiratory therapist during the time frame that you're in our program, you are going to have a job. That, I don't know if I can 100% say that if we have hospital systems that are pulling back.
That's fair. Rob, what do you think?
So from
initial takes.
Yeah, from the leadership and management perspective, I can tell you that we all know that healthcare is a fiscally challenging landscape. And I know, I read Becker's, et cetera, Harvard Business Review, and in 2026 it's going to be a very, very challenging financial year for, I think, a lot of healthcare organizations. If you think about these smaller critical access hospitals, what I think of is probably, how do we get respiratory therapists there, right? How do we entice RTs to want to work in critical access hospitals? Perhaps part of it is we don't have enough RTs applying to cover these positions. And so this is where we go maybe to the virtual respiratory therapist role. And I think that's a great opportunity for us. I think that's an avenue we need to explore more as respiratory therapists. These three hospitals are definitely smaller. I think one had 18 beds, 20 beds.
I'd actually like to get to the hospitals individually in a little bit. Yeah.
So my point is that perhaps what we need to think about is really redefining the role of the respiratory therapists in these smaller freestanding emergency departments or these rural communities, and not just have them focus on respiratory specific job description, but this might be an opportunity to say we expand the scope and expand the role, so the RT has a greater role and is bringing more value to the bedside than just measuring specific metrics specific to CPT codes that we perform. That's my initial thought.
Rob, one of the things there is I teach a home care pulmonary rehab class over the summer, and it's online. One of the projects that I have our students work on is, where do we not use telemedicine now as respiratory therapists, and where could we use it? And they have to kind of put a proposal together about where they could use it, because this generation is going to use it way more than the 5 of us did. And so getting them to be forward thinking, getting them to think outside of the box as to where they could be utilized in telehealth, I think is kind of going down that track.
Yeah. So Mike, why don't you go ahead and give us kind of the background there, so we can really
why don't we see if we can dispel some of the concern? Because I think, just based off listening to the 4 of you, I haven't even given my opinion yet, and I'm not sure I want to just yet, because my opinion is actively changing as I'm listening to you guys. Allow me to explain. As you guys are talking, there's a lot of concerns that I have with this decision, and I'll circle back to those. But I kind of have a question. And my question is related to the 3 facilities: Albert Lea, Fairmont, and Lake City in Minnesota. So let me just break down a couple different things. Albert Lea, while it's critical access, does not currently take inpatients unless they are psychiatric. They go to Austin, which is about 25 miles away, and Austin is about an 80-bed hospital. So if somebody comes into Albert Lee, into the ER, and they need to be admitted, they get transferred. Second, Fairmont. Fairmont is about 57 beds. And they are, as just from my research, you guys can correct me if I'm wrong, the only real hospital within that county. So maybe that's different than Albert Lee. Lake City is only 18 beds. And it wasn't clear if there were an additional 11 beds for a vent unit or if it was part of that 18 beds. But that's the size of these facilities that we're dealing with. And I would be remiss if I did not mention that they already have a facility in Cannon Falls that is 15 beds, but they already implemented this model. Now the difference is the one in Cannon Falls doesn't have vents. Is that too much for you, JJ?
No. It's good. I have a headache, so I'm battling through it.
It's like,
no, you're good. The timing of it was perfect, though.
So if I were to look at Albert Lee, 14 bed, psychiatric only, no inpatients, I might have a different thought than if I looked at Fairmont, which is the only real hospital in that area. And so my opinion kind of differs from hospital to hospital, which is why I wanted to bring them up.
And Mike, what I looked up, Fairmont, I don't think has 57. I think it has 37.
Okay. I might typo is totally possible.
But I agree. It's geography.
Right.
Fairmont's different than Albert Lee that has Austin 25 minutes
100%.
away. Lake City has a skilled nursing facility attached to it that has a vent unit.
Right.
That's a different conversation compared to this Cannon Falls, which appears that they have trialed this before.
Right. But my biggest worry or my biggest concern is a lot of the social media conversation has been around, without saying the word, precedent, right? People, is this where we're headed? This is a red flag, right? And so it appears to me that might be the concern. We infer that if an organization as large as Mayo is willing to implement this kind of thing here, what is my hospital going to do? I'm in a small, right?
So Mike, I have a statistic for you. So
Go ahead.
Our friend Gary Kaufman, who we know all very well, we appreciate him very much. He did a small survey of critical access hospitals. And what he says is that only 60% of those critical access hospitals that responded have 24/7 RT.
Yep.
Wow.
Yep.
So there's 40% that already practice this kind of a model, or at least something similar to.
And I will tell you, the town that I grew up in, which is a pretty significant hospital system, it's a local hospital. They did not have RT at night either.
Yep.
For a very, very long time. And they would get the initial trauma, but then ship out. But I do think eventually, when they got bigger, they did incorporate the RT into that night shift because they were the only hospital there that would take that trauma before they were shipped to a larger trauma center.
Mm-hmm. But if they took that trauma with no RT, how did they?
The doctors do the intubations, or EMS does the intubations before they get there. And then they probably bag until MedFlight gets there, to be honest.
So now I assume that smaller hospitals like that, like the one that you grew up near, I assume that they have ER techs. I assume that they might have a CNA or two, I assume, or an LPN, in addition to their RNs and physicians. What does a CNA or LVN or LPN do that an RT couldn't do? And would it be more beneficial to cross-train the RT to those duties rather than eliminate the RT who is capable of delivering a higher acuity of care?
Oh, I agree with that 100%. We can do EKGs We can put in IVs. We can draw the blood gases. We can draw the venous gases.
Out here in California, some of the hospitals have us do the pulmonary artery catheters.
Well, that, and then we can also do ultrasound. That's
Yeah.
something JJ and I are really passionate about, educating RTs how to do that, so they have that extra skill. So when we're in a situation, we'll be like, hey, we can scan that lung, or we can scan that artery, because we have that skill in our pocket.
So
Yeah,
is that a Go ahead,
I was
JJ.
in the Virgin Islands and I was able to detect a pleural effusion because we didn't have radiology. We didn't have radiology 24/7. So this patient would have sat in, their own pleural fluid and been breathless for the next 24, 48 hours until radiology was there. I also attended a webinar not long ago where they were looking at rural hospitals utilizing ultrasound to help identify if this needed to be a life flight or if it could be a ground transport. So they're utilizing ultrasound to make these decisions in facilities that don't have CAT scan.
Yeah, so that's just kind of what goes through my mind, right? And like I said in the beginning, everybody, we don't have any answers for this. I don't have any answers for this. I'm just raising questions, but I feel like the worry and the fear that becomes instilled is this going to happen to my hospital? Now, I can't imagine Mayo considering this for their main facility in Rochester.
No.
Right. So I could never imagine that. However, I can imagine, because, and I'm going to bring up transparency here. I can imagine a hospital out near where I live in Temecula that is a 150 bed hospital looking at this and going, well, if Mayo can do it, so can we, and we can save money. And that's where I look at, why I would love to find out from Mayo in a transparent sense, what was the driving force? Because there's a short-term cost in setting up the virtual RT stuff. In terms of the video monitoring and things like, there's a short-term cost involved in that. But there's a long-term potential cost savings by eliminating, if you have two therapists at the 11 bed unit, right? Say you have two therapists there and one therapist at each of the other two places. If you eliminate four therapists, you can have one therapist monitor all three facilities, in theory, virtually. There's a long-term cost savings. I seriously doubt that's the driving force. It's not that much cost. But is there also, and I'm just throwing this out and I'll let you guys talk, is there also an increase in potential liability that occurs as a result of this? In maybe not in Albert Lee where they don't take inpatients anymore, but maybe in Lake City where they have 11 vents, even if it's in a SNF. What do you guys think?
So this is a great conversation, and I love that we have a call to action, that we're coming forward with Let's Get Ethical and RT Sidebar, and this collaboration and really getting out there. From what I see, whether it's LinkedIn, Facebook, Instagram, TikTok, there's been a lot of emotion around this. It justifiably so, right? And this is what we do. Is the first thing we do is something we don't like or change, we take the emotional side to it. And so we don't have all the facts, we don't have all the figures. There's a lot of speculation as to what's going on. I do think, to everybody's point, do you really, again, I'm just going to say, do you need a respiratory therapist in a facility that doesn't take any critical care patients? Now, you can argue both sides of that. You can say, well, you're there because if this patient comes in, yeah, but in this facility, if you have providers and you have nurses, and let's say you have a couple of paramedics, can you take care of that patient before they're ready to be transferred and do it safely? Yes, you can. I think this is a bigger picture than just financial. And again, we don't know. I think this could also be the fact that perhaps they just can't get RTs to apply and work in these locations. And we don't know that, again, that it could literally be that that volume is so small that you could shift it. And I'm not saying shifting it to nursing is the right answer, because that isn't the right answer. I'm not saying shifting it to a paramedic is the right answer. That isn't necessarily the right answer. But I think in a world where we're looking at staffing constraints, I think organizations need to make tough decisions. And this could just be a tough decision that needed to be made. I don't think it's malicious in any way, shape, or form. I think it was good to see the AARC leadership come out and say, we are in contact with the Minnesota Society of Respiratory Care, because those are the two bodies that lobby, right, for the profession. I think respiratory therapists do need to get involved. If you're concerned, get involved, but get involved to make a difference, not just emotionally. Be a member of the AARC, be a member of your state society. Don't be afraid to send letters to your state senators and your state representatives raising your concern. They're there to represent you. You're a member of the community, you are a constituent. And if you have concerns about what's going on in your state in healthcare, you have a right and an obligation to come forward and make it known.
I have a little bit of a logical issue with what you just said. Hold on, Matt. I'm sorry. Not the call to action. The call to action was fine. And so let me work it backwards. The call to action, just because, and maybe you wish the AARC was a little more transparent. We're doing this. We're doing this. We're currently doing this. Maybe they can't be. They do have DC next week, right?
Yeah.
So AARC is going to DC next. They have some other things going on. It doesn't mean they're not handling this. So there may be things happening that we're not aware of. So that's fair enough. However, if I'm a hospital administrator that is having trouble getting RTs to come work at my facility, it doesn't seem to me like the answer would be to get rid of an RT. There's a flaw in that logic to me. Matt, you disagree?
No, I don't disagree. Okay. And this is where Mindy needed to chime in, because we talked about this before the call. She said something that's really important. You can advocate at a national level. You can advocate at a state level, but Mindy, you started advocating at a local level. Tell us your thoughts, because I thought that was really, really important.
Yeah, so you can be involved with the AARC, you can be involved with your state society, but if you're not involved in your healthcare system where you work, and you don't show up every single day and advocate for your patients and advocate for your job and advocate for respiratory therapy, you're not going to get noticed. You know, if you're not in rounds and you're not talking with the team and you're not showing up, then they're not going to look at you twice. They're going to be like, okay, they're not here when we really, really need them. So, yeah, I think if you start there, you work there, you should advocate for yourself while you're at work.
That's a great point.
Yeah.
All right. So, Mike, you've been handling the moderation. It's time to put you a little bit feet to the fire.
All right.
What is the value add for respiratory therapy right now? What is the value add? So if you're at the Mayo Clinic and you're at one of these facilities, what is respiratory adding value to?
So that's a great question. And I don't look at it. I look at it. Let's look at it in terms of what value are you removing by eliminating that therapist at night?
Okay.
In what way are you limiting yourself? And there's several different avenues that you have to consider. And this is where a lot of the social media posts have been absolutely correct. Nurses, physicians, CNAs, LVNs, LPNs have to pick up your work. They have to do more, and they're already overworked, right? At the same time, you're not replacing that critical assessment skill that we bring to the table. Assessment is a series of checks and balances. Everybody misses something sometimes. And if we're not at the table to be part of that check and balance, there is potentially something that can be missed that can be life-threatening. And I've read a couple different things. One said 0 to 10, one said 5 to 10 patients on average are what these patients are seeing overnight. Now, I don't know if that's 5 to 10 at each facility or 5 to 10 as a whole. But if it's potentially 30 lives at risk every month, that's 30 times the lives that I think about.
Could have helped. That you could have helped.
100%. And so to me, that's where I go with the cross training. Rather than remove me, who has this acuity of care available to you, remove somebody who, an ER tech or somebody else. I can also do their job when I'm not busy. No big deal. I have no problem doing that. And personally, I've in my work experience, I take, obviously I check if they're NPO, but I'll go refill their water bucket. I'll get them some ice. I'll come sit with them and give them ice chips. I'll go get the nurse. I'll go grab them a blanket. I do those things, right? Those are kind of outside of our job description, but it's not, because at the end of the day, it's patient care, right? It's caring for that family member that's in the bed. And by removing me, you don't remove the blanket and the ice chips and the water. You remove the critical assessment skill that's available to those patients.
And I think that's the biggest thing.
Yeah.
And JJ, I'm going to go back to you because I spend a lot of time talking to you about what do you teach students? So Mike and JJ are educators. You don't teach vent checks. You don't teach slinging nebs, but you teach two things that are really important. And to me, it's assessment and ventilation skills.
Right.
JJ?
Yeah, I mean, it's so funny because we talk to our students all the time. We do two things really well: oxygenate and ventilate, right? And if one of those two things goes down, who are you going to call, right? My very, very, very first TikTok, I think it was about, like, it was probably overnight, but I said, what's more important than breathing? And I had a little pause. And then Cat Williams came in and he said, there's nothing more important than that, right? Don't worry, I'll wait. And that was my TikTok. That was the whole thing. And that's the idea, is that when you have somebody with the skill set of a respiratory therapist, they are more than a task doer if they are utilizing their skills appropriately. If they are. And now, if they're one that is going to look at their sheet, their brain, knock out the number of breathing treatments that they have, and then go check out Wheel of Fortune, that is not that's not a big benefit to the facility, right? So you have to recognize what your role is as a respiratory therapist, and you have to make sure that you are not replaceable. Are you picking up skills as, like, learning what a sterile environment looks like when somebody's doing a chest tube, when somebody's doing a central line, a PICC line, midline, arterial line, and saying, hold up, like, you just broke sterility and we need a new set of gloves, right? Are you doing that? If you're not, then you're exposing the opportunity for your patient to get an infection from that procedure, right? That goes well beyond slinging nebs and writing numbers down as a respiratory therapist. It goes well beyond that. And what are you doing?
So there are hospitals, and I'm going to just use Children's Hospital of Philadelphia as an example, where their model, and they did this years ago, where they partnered respiratory therapists with nursing on inpatient respiratory units. And so the RT was there to take care of the patient from a respiratory standpoint, but also to help get vitals, et cetera, along with nursing, and work collaboratively so that you still had the skills of the RT, you still had the assessment skills, but you were taking them and saying, we're going to broaden your horizon, and we're going to have nursing and respiratory be together, almost working as one to provide better care for the patient. So perhaps the direction here is not just you. Again, I think virtual RT has a place. I think it's growing. I think that's an opportunity for us. But to your point, if you're going to have an LPN or an LNA that cannot practice at a higher level, but we can practice at that higher level. Oh, and by the way, we can also pick up these other skills along the way. That's the value add right there, right? To your
100%.
Right.
point, it isn't slinging a neb. It isn't a ventilator check. It's the
Right.
assessment skills and saying, hey, you're an RT. You're not just going to be at this level. We're going to get you to this even higher level. And I think
There
that's where
was
we all go ahead,
go,
please.
I was just going to say there was something that I read years ago, and they stopped talking about interdisciplinary rounds, and they started doing transdisciplinary rounds. So it blended nurses with RTs, it blended nurses with pharmacy, and you don't have this is my sandpit and you can't play. The lines were truly blurred with where my stop is and where your stop is, and we have this overlap. So I don't remember where that was, but they talked about these transdisciplinary rounds so that everybody had a part to play. Maybe that's something that we look at, and it's a verbiage thing, and you kind of break down these barriers, break down these walls so that you can see how well we play with others.
Mindy, go ahead.
Lots of times, helping the nurses out where I worked, I wasn't afraid to get down and help clean up a patient when they, had a bowel movement. I'm not afraid of poop. That's just something I'm not afraid of. But I just went the extra mile to kind of show, hey, yeah, I'm useful. I can't just do my respiratory stuff, but I do other things too. And I think that's where a lot of our Ts need to step up a little bit more and kind of help the nursing, because we work together. It's not, oh, you're RT and you're nursing. We're a team because we're working for that patient.
I mean, I would tell people that I would help turn, but I can't wipe.
Well, we all have a poop phobia except Mindy. That's true. But I'm going to ask.
Her willingness to deal with poop is the reason she can deal with the four of us. Let's be honest.
That's exactly right. But I think I'm gonna ask a provocative question to my friends here. Okay. Are we mad about this because someone defined our role without us defining it ourselves?
Oh, that's a great question. And I would say that I personally think the answer is yes, whether we want to admit it or not.
Yeah, I think you basically told me what my limitations are. And that irritates me because in Texas, if you have a hospital competency for it, you can perform that skill. You can perform that procedure. And there's a lot of states that have something similar. And by removing me from this position and not seeing how broad my scope is, it's limiting, and I don't like that. You put a ceiling on me.
Yeah. So instead of saying where's the value add, right, isn't just based upon a task, where's the value add? To your point, we were just being removed from the equation without any input. And I think that does draw a very heavy emotional response from people, and that's what we're seeing.
Yeah.
And it's I am thrilled to see support from providers. I am thrilled to see support from our nursing colleagues. I think that's wonderful, but we have to be logical thinkers too, and not just have an emotional response, because that doesn't get us what we want. That's not going to get us anywhere. So how do we change the narrative in this situation so that we benefit and grow the profession of respiratory care?
Matt, I need a little clarification on your question. And this comes, thank you, JJ and Rob and Mindy. This comes from listening to you guys in response. Are you asking if we're mad at the therapist who may not have added their own value like we have been discussing? Or are you asking that? Or are you in terms of someone else limiting me?
No, I don't.
Or,
go ahead, Mike. Sorry.
Or are you asking if we're mad at, and I'll say the organization, I don't mean Mayo, I just mean in general, the organization, the wheel, the machine.
C-suites.
Yeah. at
That's where it
limiting
is, right?
Yep. 100%.
This is a C-suite versus scrub conversation.
Okay.
To me, C-suites made a decision that they're not going to have RTs, and RTs are pissed.
So then my answer then is no, I'm not mad at that. I'm not angry at that. I'm worried at, like I said earlier, I'm worried at the potential for a precedent to appear to have been set with another organization who may decide that, quote, Mayo did it, so it's going to be okay.
How many other
and that's a big
suits
deal.
are going to call the Mayo Clinic and say, how did you make this happen? Right. And
Right.
that could be a valid concern.
Why did you make this happen? That's the problem.
They're going to say how. How did you do
Exactly.
this? Not why.
And
there's a lot of managers and there's a lot of directors that are going to be fighting those conversations in those meeting rooms.
Now, am I at the therapists who potentially didn't add the value? And I don't know that that is the thing. I'm not sure that that's the situation, but if it is, yes, I'm angry at that. I take respiratory therapy very personally. And when
we all do.
When I'm not saying you don't, I didn't mean it that way. Sorry.
No. Of course,
something like this happen. My first thought is, how many movies did they get through in a night? Because they see that, and the nurse manager will see that and report that. And when they're looking at making cuts, they say, well, who can we cut? The dude not doing anything. That's who we can cut. I see the CNA in the ER because she's assigned to the ER. I don't see respiratory all night. We need to get down there. So if that's the case and that happens, I get angry at that. I don't get angry at the C-suite making a decision on the other end. I get worried at the consequence of that decision.
So we had in Pennsylvania Society for Respiratory Care, this is probably 4 or 5 years ago, we had a consultant for Premier come on board. And they say, where are your top 10 places to cut? Respiratory therapy was on that list.
That's horrible.
Of places to cut. So it's disgusting. It's horrible. I'm not going to say that it's not. So when it comes to, did you watch Wheel of Fortune or The Price is Right today? But I also, when I think about like defining our role, Mindy, I'm going to go to you. And this is, you go to your current job. You're the first APRT ever. And you have all the hopes and dreams that you've ever had. And they say you can't prescribe opiates, you can't adjust ventilators, you can't do these things. Somebody else told you you can't, even though you know you can. That is what I think is the problem here.
Yeah.
That's what I think it is.
Yeah, I agree with that. I think it's just it's limiting you. You can't break through that glass ceiling and show what you have to offer if you're limited on your skill. So I think personally, there's a time and place for virtual RT. There's plenty of options: tobacco cessation, pulmonary rehab, pulmonary disease navigator. Those are perfect places to have virtual RT, right? I don't think any hospital, even if it's a small hospital, should go without having a respiratory therapist. I just don't.
I agree.
Yeah, I agree too. But it's again, it's a difficult. It's not as easy just saying we want an RT. How many RTs do you need to cover 7 days a week, 24 hours, 365 days a year? And if you don't have a pool large enough to cover that, and we are stuck, you're right, healthcare is a world of where we measure everything based upon productivity. And sometimes, not picking on the C-suite people, but sometimes the C-suite people set unrealistic expectations for your productivity. And we know you can't be productive 100% all the time. That's not possible, right? We know that there are peak periods where we are seeing patients and we're busy, or we're seeing routine therapy patients. And then we have periods where our productivity is, right, zero. We're not productive. That's how every healthcare system works.
Well, I think it's non-productive in terms of a CPT code.
It is
right?
non-productive, but it's
When
built
Mindy
into
goes and wipes a tush, right? That is productive.
it's
There
not
is
though.
but
It's
not
not.
on paper.
It's not. From a finance perspective,
Yeah,
sure.
Bill,
that is not, because you're only basing your productivity on your CPT codes, and it's based upon the RVU, or the relative value unit, in the weight of that CPT.
Mm-hmm.
And every organization looks at those weights differently. Yes, the AARC has most recently put out an excellent, the safe and effective staffing guides.
Mm-hmm.
Yes, they give you a great roadmap to properly calculate your productivity or your weight for each specific task. But your organization's finance department, right, the bean counters, have to buy into that.
Yeah.
And if they're not going to buy into that, and your productivity for each of those CPTs is only going to be X, it's either going to positively or negatively affect your productivity. And there are things that we do as respiratory therapy, and this is where the argument goes of getting away from that process and really looking at it from what is the value add that respiratory therapists bring, until we truly can get that factual. We're going to continue to struggle like this. And I think that's just a cold hard reality of where healthcare is right now in 2026.
Now I have a question. So what if you had your virtual RT, but then they decided, let's have a local RT be on call for when we know we're going to get a respiratory patient coming in via EMS? Would that be something that would be logical? You have your on-call RT throughout the week. They don't come in unless they're needed. So it's like a PRN thing. And you have your RT virtual overseeing everything, who can contact that RT who's on call for that shift and say, hey, we have a cardiac arrest coming in 3 minutes away. And then RT.
Yeah, I have an instructor who functions just like that in a small facility. She is on call. When she's on call, they call her for the cardiac arrest, for the respiratory arrest, for the intubations, and the blood gases. Outside of that, the rest of the staff takes care of it.
Mm-hmm.
I think it's an excellent idea, honestly.
It is a good idea.
But it's not, and that's not a new concept. There are hospitals that do that now.
Yeah.
Right.
Not new.
Right.
The virtual RT is new, but having somebody in these smaller hospitals, and sometimes some of the hospitals, even up where I live, there might be an RT in-house sleeping, but they're in-house and they're getting paged when they're needed. But again, the bean counters, and I'm not picking on bean counters, might say, is there value in us paying for this person to be here and sleeping?
And a lot of times the bean counters will pay for sleeping people because they're required regulatory to have them there. Now, I will tell you, a great opportunity is RT Now. RT Now is a virtual place, but what they do is they have regionally placed RTs that when they need somebody there, they got them. So it to me, this is a supply demand issue, but it's also getting the talent to the right place at the right time.
Agree. And that's a value equation, right?
That's a value equation.
That's a value equation. Yeah.
So we've raised a lot of questions and answered none, which is what we wanted to do. That's the whole goal here. So I will tell everybody watching, RT Sidebar and Let's Get Ethical, we actually need to hear from you on this topic more than ever. We need to know where people stand. We need to know how we can have these conversations, because this isn't going to be the last time that we have an episode about this for Let's Get Ethical. And I know RT Sidebar, I'm sure they're going to have an episode or two about this, or even more. Or five, yeah. In the meantime, we need to know where these conversations need to go. And every voice matters. And so if I could say anything to everybody before I throw it out to the four of you guys, what I would say is we would love to help you advocate, but we need you to help us advocate for you, is what I would say. What do you guys think as we close up here?
Boots on the ground, grassroots, be involved, right? Be involved at the ARC level, be involved in your state society level. And again, don't be afraid to reach out to your politicians, right? You are their constituents. They want to hear from you, and their job is to carry our concerns as citizens forward.
Mm-hmm. I would keep it local. All right. So to me, work in your hospitals, but keep it local to these podcasts. Keep it local to Linda Nozart. Keep it local to Carrie McClure. These people are really talking about important stuff.
Yep.
And put in the comments questions, not comments, questions. And RT Sidebar, let's get ethical, get on our YouTube, get on our socials, and ask questions, because you know what? We listen and we're going to talk about it. So please do that, because I think that that's what is most important to me.
Mindy?
I want RTs to be active in their hospital settings. Advocate for yourself. Be present, not only for your patients but your team, and be able to say, "Hey, this is happening. What can we do to change that?" Then you're a force. You become a force.
For me, this whole conversation has been a debate between my head and my heart. My heart and my passion is for respiratory therapy. My head understands the physical responsibility that a hospital has. So for me, that is what my internal dialogue has been. But I am going to lean more towards my heart in this, because this is my passion. This is what I do. I help create the next generation of respiratory therapists. So even though my heart is in it way more than my head, it's not, my head is not being unheard, if that makes sense.
Well, I like that. And I think, shoot, with that, you know what, Rob, why don't you take us out?
All right. So everybody, thank you so much for joining us today. It's been a pleasure having our friends from RT Sidebar on. And
thank you guys.
An absolute great debate. And to Mike's point, we didn't solve anything, but we've opened up the conversation and we want to hear from you. So everybody, join us next time on Let's Get Ethical.